Hello, welcome on this webinar. My presentation will be on what is new in the management of infant constipation. That's the layout of my presentation, and we'll start, of course, with definition about functional constipation. But functional constipation is one of the functional gastrointestinal disorders that, as you can see here, last from birth up to toddlerhood, childhood. So functional constipation is one of those functional disorders which is not limited only to infancy, because it continues. And you talk about functional gastrointestinal disorder when the recurrent symptoms attributable to the gastrointestinal tract cannot be explained by structural or biochemical abnormalities, and they are quite common. Now, one of the problems with functional constipation is how to report it, because this paper from some 5 years ago showed you that in 45 different trials, not less than 22 different definitions of functional constipation were used, which is, of course, leading to a lot of confusion about when do we talk about functional constipation? What is the exact definition? Therefore, it was very useful to have the Rome 4 criteria, which diagnose functional constipation as the following criteria. It must include in 1 month of at least 2 of the following in infants up to 4 years of age: 2 or fewer defecations per week, a history of excessive stool retention, a history of painful or hard bowel movements, and a history of large diameter stools, together with a presence of a large fecal mass in the rectum. So, functional constipation is constipation without an organic cause. And we use the term fecal incontinence as involuntary loss of stools after the age of 4 years. And other terminology is encopresis or soiling. And we use fecal impaction as a hard mass palpable in the lower abdomen during physical examination, and or a dilated rectum filled with a large amount of feces with rectal touch. And constipation is definitely different from dyschezia, although they are frequently mixed up. But dyschezia is a form of difficult defecation which is briefly present between the ages of 0 and 6 months and disappears spontaneously after a few weeks. It concerns healthy children who press and or cry for at least 10 minutes prior to defecation, with or without results. And this condition requires only reassurance from the present parents. And the stools have a normal consistency in dyschezia, so there is no constipation, although defecation is painful. So diagnostic criteria for infant dyschezia, according to Rome 4 criteria, say the following. They must include in an infant of less than 9 months of age at least 10 minutes of straining and crying before successful or unsuccessful passage of soft stools. And there are no other health problems related. Now, what about the prevalence of functional constipation in our infants? Well, as already said, functional constipation is a common childhood problem with varied prevalence between geographic regions. So in North and South America, the prevalence is reported between 10 and 23%, while in Europe, figures between 1% and 12% are reported. And in Asia, figures are reported between 0.5% up to 30%. But so a huge discrepancy, but also a huge range between 1 up to 30% of all the infants and children suffer with functional constipation. So this figure gives you an idea about the different prevalences reported all over the world, ranging from about 6% up to 30%. Prevalence in infants we reviewed the literature that was published some 5-6 years ago and did find 8 different studies focusing on the prevalence of functional constipation in infants. And we found that the percentile 50, the median value, was about 8%, with the interquartile range between 3.8 and 15%. And the red dot that you see is the personal opinion of 500 different pediatricians worldwide, just asking for their subjective impression how frequent functional constipation was in infants in their daily practice. And then the median value was about 15%. So overall, we can say, I think, that according to literature, the frequency, the prevalence of infantile constipation is between 10 and 15%. Although these data from Europe collected in tertiary care centers in the Netherlands, in Belgium, and in Italy report an incidence of functional constipation in infants, which is much lower, which has a median value of only 3%, while it reaches 10%, 9.7% in children 1 year up to 4 years old. According to these data in African infants, the prevalence of infant constipation is 30%. So still a huge discrepancy, probably depending also on the healthcare level where you're going to collect the data. And of course, functional constipation is mainly a problem which is seen by primary healthcare. And so in the tertiary healthcare level, you see much less infantile constipation. What about constipation and cow's milk allergy? We know that cow's milk allergy is frequently associated with infant constipation, but constipation as single manifestation is only seldom a presentation of cow's milk allergy. What about the diagnosis? How do you best describe stool consistency? There are different types of poop which are described on a very humoristic way on this slide. But that's, of course, not a very scientific way how to describe it. What we most of the time use is the Bristol stool scale, which you see illustrated here. But we all agree that the Bristol stool scale has been developed to describe stool consistency in adults and not in non-toilet-trained infants. In infants that make stools in diapers, stools do not look like this. So that's why other stool scales needed to be developed. And the first attempt was the Amsterdam stool scale, or the Becali scale, which was published already more than 12 years ago, looking at the volume, the color, and also the consistency of the stools, but which was quite complicated. So we developed with a group of co-authors the BITS, the Brussels Infant and Toddler Stool Scale, which described the stool consistency according to 4 different categories: hard stools, formed stools, loose stools, and watery stools, according to photos which had been made and selected. And a machine learning tool has been developed, which will result in when you make as a parent or a physician a photo of the stools in the diaper, the app will answer you about the stool consistency, which will make it much more objective in the future. So now that we discussed definition, prevalence, and diagnosis, let's look at therapeutic options. First, magnesium sulfate. Well, magnesium sulfate has a long history in the treatment of functional constipation, and magnesium sulfate-rich mineral waters have been used for centuries for their laxative properties. And that's illustrated in this recent publication from our colleague Christophe Dupont, who looked at different mineral waters rich in magnesium, which had been tested for their efficacy in functional constipation. And this literature shows clearly that mineral water with a high level of magnesium is effective in the management of constipation. But there are limitations to that for our infants, because very often those mineral waters are also associated with increased intake of other minerals. So these mineral waters are very useful for adults and older children, but not so much for our infants. So what's the rationale for the use of probiotics in infant constipations? Because we know that there are differences in the intestinal microbiota composition in healthy and constipated infants. There are less bifidobacteria, more Escherichia coli, more Bacteroides, and there is an increased total number of microorganisms. So what does the literature tell us about the probiotics for functional constipation, focusing on the Bifidobacterium lactis HNO19? Well, there are at least 5 different studies which all report that this specific probiotic, Bifidobacterium lactis HNO19, is effective in the management of functional constipation in infants as well. So differences in microbiota are present in constipated infants, but we just looked at the efficacy of probiotics. What's the efficacy of prebiotics then? Using, for instance, inulin. What is inulin? Inulin is a non-viscous soluble fiber with prebiotic effects. It stimulates the growth of bifidobacteria and lactobacilli and reduces the number of certain pathogens such as Clostridia. And due to its long chain molecules, inulin is likely to be slowly fermented in the large bowel, thus prolonging its effect in the transverse and distal colon. And prebiotic inulin-type fructose supplementation has been shown to improve stool consistency in constipated 2 to 5 years old children, as illustrated on these slides. And what about galacto-oligosaccharides? Well, GOS or galacto-oligosaccharides are commercially available, and they are short-chain galactose units with terminal glucose molecule, which is produced from lactose. And GOS is not hydrolyzed by human digestive enzymes, but is fermented by colonic bacteria to short-chain fatty acid. And GOS stimulates the growth and metabolism of intestinal bifidobacteria, and GOS supplementation is shown to improve stool consistency. So prebiotic effect of GOS has been shown in different clinical trials. Here you see 3 different clinical trials reported, and compared with placebo, GOS was associated with improved stool frequency, improved stool consistency, and relieved defecation straining. And what about carobin gum? Well, carobin gum is a milk thickener, but it's also known as locust bean gum, but it's obtained from grinding the seed kernels of the carob tree. It's a natural, soluble, viscous, indigestible, but fermentable fiber. So it is successfully used for dyspnea and special formula milk for infants. And 2 specific characteristics of carobin gum are its ability to act as a thickening agent, and it is also a dietary fiber when supplemented to nutritional formulas. So carobin gum is an effective milk thickener, and one of its adverse effects is diarrhea. So it softens the stool, so it's effective in constipated infants. This slide tells you about the effect of a whey-predominant starter formula containing long-chain polyunsaturated fatty acid and oligosaccharides GOS-FOS on gastrointestinal comfort. And it shows you that this kind of formula is very effective in decreasing hard stool frequency in in constipated infants. And what about the effectiveness and tolerance of a locust bean gum thickened formula in a real-life study? Well, what this study did show, it's a very recently published study in over 2,600 infants, that stool frequency increased and stool consistency softened to levels within the physiologic range consistent with the increased fiber load. So carrot-bean gum improves gut microbiota also and supports gut motility. So carrot-bean gum has been shown to support gut motility and promote a more varied microbiota, enhancing the growth of lactobacilli and bacteroides, which are associated with maturation of the mucosal-associated immune system. And carrot-bean gum is also associated with lower gas production compared with moderate and rapidly fermented ingredients. So carrot-bean gum supports gut motility, it improves the gut microbiota, it enhances the growth of lactobacilli, and it is associated with lower gas production. So carrot-bean gum and GOS, what are the working mechanisms? Carrot-bean gum stimulates beneficial lactobacillus and acts as a thickener in infant formula and results in a healthy intestinal microbiota. And GOS stimulates the growth of beneficial bifidobacteria and lactobacilli and improves stool frequency and stool consistency and results in a healthy intestinal microbiota. And so the combination of both will result in a reduction of digestive problems and a better tolerance. And what about milk fat? Well, the proportion of palmitic acid, one of the major saturated fatty acids in breast milk, is in the SN2 position, which is different for specific types of fat. And so the SN2 predominant position of palmitic acid promotes optimal digestion and absorption of fatty acids and calcium. And natural milk fat from bovine milk has high SN2 palmitic acid content. And what we see in what is the risk factor in infant formula containing often palm oil is that SN1 and SN2 3 positions are used, which increase the risk for formation of calcium soaps and which will result in hard stools. So the effect of milk fat-based infant formula on stool fatty acid soaps and calcium excretion in healthy infants is reported in different crossover trials, showing that 50% milk fat formula also showed improved stool consistency. So the use of milk fat in infant formula could be an interesting approach to improve gut comfort and stool characteristics in infants. And what the effect on milk fat on crying time and stool characteristics in Chinese infants as reported in this study. What these authors did report is that lower fecal fatty acid soap levels, fussy crying time during the night and gut discomfort were observed. And these findings, of course, contribute to the current understanding of the association between lipid structure and gut comfort parameters. And hydrolyzed formula does result in softer and more frequent defecations than formula with intact protein. Which brings me to conclusion of this presentation. As a healthcare professional, when we see parents which consult us because of functional gastrointestinal problems, we should always educate and reassure those parents, telling them that there is no disease, that it will go over in time, and try to stay away from medication because there is no disease. And we can use nutritional treatment, appropriate infant nutrition, which will endorse our education and reassurance and decrease the symptoms in the infants, which will result to the fact that the infants become symptom-free and are as a consequence more happy. As a result of that, there will be less clinical consultation and less healthcare costs. And as a result of that, parents will be settled and confident and happy. And as a result of that, we as healthcare provider will also be satisfied and happy. So how to treat infant constipation? Well, you should look at the presence of warning signs, which look most of the time to anatomical problems, development problems, neurological problems, also cow's milk allergy. Most of the time, the answer to these questions will be negative. So then it's your diagnosis is probably this is functional constipation. And so reassure and educate the parents and continue certainly breastfeeding. Functional constipation in breastfed infants is exceptional. In formula-fed infants, verify proper formula preparation and consider formula with increased magnesium levels or high magnesium levels, partially hydrolyzed formula with prebiotics, with probiotics, with milk fat. And that most of the time will result in sufficient improvement. And if that's the case, you just continue with this kind of therapeutic formula. If that is insufficient, consider then the additional use of lactulose or polyethylene glycol in infants older than 6 months, or consider cow's milk protein allergy as a possible diagnosis and switch to an extensive hydrolysate. And with this last slide, I would like to thank you for your attention and hope that you enjoyed this webinar. Thank you very much.
We have one question for Prof. VandenPlas. The treatment for a lot of times babies get constipated when we start complementary feeding. What would you advise parents when that happens?
Well, I think that's a very good question. And when that happens, that means that your infant is already 6 months older or older
Yes.
if you follow the WHO
Yep.
recommendations. So it depends a little bit on how important the milk feeding still is. If that's still breastfeeding, of course, you continue the breastfeeding. And then I would add some polyethylene glycol, if available, or lactulose to manage the constipation. If the infant is partially formula fed, you can also then switch to a formula which has been developed to manage infant constipation. So
Okay.
my management would depend on whether the infant is still breastfed or formula fed while be giving solid food.
Okay, thank you. You mentioned a little bit about the use of probiotics and prebiotics. Would you recommend any particular probiotic for functional constipation, and how long would you give it for?
Well, I think the message is that you should use only those probiotics and prebiotics which have been shown in clinical studies to be effective, because not every probiotic that is commercialized is effective. So clinical proof of efficacy is absolutely important. How long? Well, it's absolutely considered as being safe for the general population. And so the duration is, I would say, of no importance, and there is certainly no time limit. So you could stop it after a couple of months and see what happens, but there is no risk for adverse event if you continue the probiotics too long. And the same is true for the prebiotics.
Would you be able to suggest which probiotic you would recommend?
Well, again, as I said, these ones which have been clinically studied. So you should look at these infant formulas on the market with probiotics, prebiotics that have been clinically studied in infant constipation. Or if you want to prescribe probiotic as a food supplement, then again, look in literature what has been published about this specific probiotic that is available in my country in the indication I want to use it.
Okay, thank you. You mentioned briefly that that occasionally already cow's milk protein allergy could be a contributing factor. What would be the clinical suspicion to make you think that cow's milk protein allergy was contributing towards constipation?
Yeah, that's also a very good question. I think that if you look at the symptoms of cosmic protein allergy, constipation is always part of the possible symptoms. On the other side, if constipation is the only single manifestation, then cosmic protein allergy is probably only very rarely the cause of the issue. That's why in my algorithm it came at the very last possibility, because most of the time infants who have cosmic protein allergy have a combination of different symptoms. So constipation as the single manifestation is exceptionally caused by cow's milk allergy. Most of the time, those infants do also have atopic dermatitis or other symptoms. So it's combination of symptoms and family history who should make the healthcare provider think about the possibility of cow's milk allergy.
Okay. There's one question on in a totally or exclusively breastfed infant with constipation. I'm assuming after we started complementary feeds, is there any way between using laxatives such as lactulose versus probiotics? Which one would you go for?
Yeah, good question again. I would like to repeat again that some infants which are exclusively breastfed produce 7 stools in 1 day, and other infants produce 1 stool in 7 days. But most of the time, those infants do not have any symptom, and so constipation during exclusively breastfeeding is really exceptional. When there is solid started, I would go for what is easiest available. Lactulose is certainly also safe, and but is fermented in the colon, and so one of the adverse effects of lactulose is
Yes.
flatulence and cramps.
Yes.
While with probiotics, the overall literature on probiotics as food supplements administered for constipation is very weak for efficacy in management of constipation.
One question.
Recommendations say to use lactulose. That's actually what is the first option.
Someone has asked, what is the ideal time to start cow's milk in children? I'm assuming this would be the unmodified cow's milk as opposed to uh, infant formula. So when would you recommend starting unmodified pasteurized cow's milk?
You ask it to me.
Anyone, yes.
Okay, well, I think it's not yet clear from literature. In Belgium, we have a recommendation to go on with growing up milk up to the age of 3 years for reasons of the protein content in cow's milk, which is much higher than in the good growing up milks, but that's certainly not a general recommendation. Prof. Yanis, you want to add something?
Yes, I agree with Professor VandenPlas. There are recommendations for up to 3 years, but this is not like scientific recommendation. I would not say a legal recommendation. The recommendation to use infant formula, modified infant milk, is for up to 12 months. But theoretically, based on legislation, after the 12 months of age, parents can use pasteurized milk. As Professor VandenPlas mentioned, whether this is the best choice for the infant or not, that will be decided by the parents and the pediatricians recommending the product to the parents.
Yeah, I suppose it will also be taken in the context of what else the child is eating, right? If the infant or toddler has a fairly well balanced diet in terms of the complementary and the solid eating, then maybe it doesn't matter whether they're taking growing up formula versus infant formula in that fresh cow's milk in that sense. Okay.
Yeah, I
What?
think that, sorry, I would like
Yes.
to add, I think
Yes.
that's really the issue, what you're saying, because
Yes.
indeed, if there is healthy diversification, you don't need the low protein growing up milk.
Yes. Yes.
However, if you look at what toddlers eat in Belgium, more than 50% of the infants eat more than 300% of the protein intake. And so or you try to change the dietary habit of the family, or you try to change the composition of what those infants are drinking. And by just changing regular milk to growing up milk, we decrease that intake of excessive protein with over 50%.
Yes.
Yeah.
And I think there is. Yes, go ahead, Prof. Yanis.
I totally agree with also Professor VandenPlas to this, and I would, if I would recommend and follow formula to a family, I would not have in mind the most important for me issue would not be the protein, because as also Professor VandenPlas mentioned, protein is coming from many other different sources for these age kids. But I would recommend it basically because of other, for me, important ingredients, for example, vitamin D fortification or omega-3 fatty acid, issues that cannot be really provided by the rest of the diet of those toddlers.
Okay. All right. Another question on constipation. Any recommendation for adding fiber to infants who are constipated after the age of 6 months? So in the slightly older baby.
Yeah, well, fiber or prebiotics, I think that comes to the same. You add something which is fermented in the colon and which soften the stools.